Hello, everyone, and welcome to another episode of the Ask a Doctor show, where guess what? You get to ask a doctor your questions. Today, we're going to be talking about shoulder arthritis, and we'll be talking about that with Dr. Brandon Money, one of the great doctors, one of the few great doctors at the Centeno-Schultz Clinic. And let me clarify, I don't mean that there's a few doctors at the Centeno-Schultz Clinic. I mean, there's a few doctors in the world that are great enough to work at the Centeno-Schultz Clinic. And of course, if you're following this page, you know all about that. Dr. Brandon Money, good afternoon. Thanks for taking some time out of what I know to be your busy procedure schedule today to answer some questions that people need to know so that they might, if necessary, be able to come in and get some help from you. How you doing today?
Doing great, Jason. Thanks a lot. I appreciate it. Thanks for the opportunity. And it really, truly is an honor and a privilege to have the opportunity to work at the Centeno-Schultz Clinic and be one of the few physicians that are accepted into this practice, because it's not something that the average or even the above average or even the exceptional physician can attain.
You know, I think we should start exactly right there. There are quite a few people that I know who, when I do these types of programs, when I talk to people in the public, they sort of do doctor shopping. And they think, hey, I've got this problem and I need that solution. Where is the closest, cheapest option that I can go to get that handled? As you sort of basically just explained, most people don't know how difficult it is to, in fact, go through a fellowship, and not only go through the fellowship, but then actually get accepted to stick around after the fellowship. Before we get into shoulder arthritis, that's probably a great place to let people know what's it like? How difficult is it? What's the competition like? I'm sure you weren't the only one who wanted to be there. Why don't you start off and kick off today's program explaining to people what kind of Olympic sport it is, what it means to win a gold medal and be, the winner of the competition it takes to be at the Centeno-Schultz Clinic.
Yeah, absolutely. So medical school is 4 years in duration, and then I'll just go through kind of the process that it takes, because lots of people, there's some misconceptions. People don't know the duration of time and training that it does take. So medical school is 4 years. Typically, the first 2 years are in the classroom, predominantly, where you're learning about basic science and cardiology, physiology, all that kind of stuff. And then the next 2 years you're spent in the hospital, rotating in surgery, orthopedics, pediatrics, internal medicine, emergency medicine, all those rotations, and then you decide, okay, what do you want to specialize in? Because you can be an emergency doc, you can be a general surgeon. So then that's the specialty of residency that you apply to, and then so you have to get accepted into a residency program of that specialty. And in my specialty, physical medicine and rehabilitation, there's about 70 programs, I think, now, all throughout the country. We're one of the smaller specialties. All of the physicians here at the Centeno-Schultz Clinic are either trained in physical medicine and rehabilitation or anesthesia, pain medicine. And then after that, after residency is complete, which for my specialty was 4 years, it ranges anywhere from 3 to 7 years. Those crazy neurosurgeons take 7 years of training, because if you want somebody doing surgery on your brain, they better know what they're doing. Anyway, so then after residency, then you can opt to apply for fellowships, which is additional subspecialized training in a very specific field. So the good thing about the Centeno-Schultz Clinic specifically is that they offer a fellowship in interventional orthopedics, which is the kind of terminology for what we do here. So it's orthopedic medicine, but we don't do surgery. Mostly, as far as our treatments are concerned, are done with a needle. So we're putting a needle exactly where it needs to be, and whether that's your neck, low back, shoulder, hip, knee, ankle, any one or all of those areas, depending on the patient. We have that extra specialized training to, number one, know how to diagnose the condition properly, and then number two, be able to treat it appropriately if we decide that we think you can benefit from our types of treatments. And not all patients are at that point yet. Some patients come to us and say, I haven't done physical therapy, I haven't taken any natural anti-inflammatories, medications like that. So we may start at a lower level and see where that gets you. But by the time most people get to us, most patients get to us, they've been through maybe multiple surgeries. They've been to 20 different doctors. They've tried steroid injections. They've tried all the traditional medical things, which that's why they end up in our inbox and our exam rooms.
You went exactly where I wanted you to go, and that's for people to understand that all medical doctors, all DOs, doctors of osteopathy, are not the same. And what does make your practice stand out uniquely is the fact that, and this sounds almost like a contradiction, but here you are, medical doctors, doing everything you can to help people minimize their use of drugs and surgery, which almost sounds kind of antithetical because isn't that what doctors are supposed to do? But help us understand, why you end up sort of, I think of you guys as sort of the last resort for exactly the reasons you're describing, which is people try all of the, I'll say, convenient, local, and oftentimes, oh, that's covered by my insurance. It's easy. I can just go down the street. My doctor's so nice, and they take my insurance, and yet end up in your office and sometimes traveling from either anywhere in the country, sometimes even worldwide, to come to your practice. How do you describe why they do that? What's the difference?
Yeah, the difference is the tools that we have in our toolbox. Traditional pain management, orthopedics, etc. I'm certain that they are good and or great at what they do. But we have additional tools in our toolbox to be able to diagnose properly, meaning a comprehensive musculoskeletal examination, reviewing any records that you may have, reviewing any imaging that you may have had done, and we put all of that information together to be able to make the most accurate diagnosis that we have. And our clinic is special and different in that when you come and see us for the first time, we spend anywhere from 45 minutes to an hour with you doing those comprehensive evaluations. And the traditional health insurance model, they simply can't spend that amount of time with you, and you get 10 minutes, 15 minutes, maybe if you're a new patient, 30 minutes, and they do a quick evaluation and then they utilize those tools, whether it's steroid injections, whether it's radio frequency ablation or burning the nerves, or if they say you've done all this stuff, it hasn't gotten you to where you want to be, then we send you to the surgeon, and then the surgeons, surgeons get paid to do surgery. Let's be honest. And so those are the tools that they have in their toolbox. And technically, I'm sure they're great surgeons, but we've realized over the last 16 years here at the Centeno-Schultz Clinic that a lot of surgeries can be avoided by using your body's own ability to heal.
Let's go right there, and then we'll dive into specifically today's topic, shoulder arthritis. Meanwhile, if you're watching and you've got questions about shoulder arthritis or anything that we're talking about, now's a great time to ask. So one of the main differences, I guess, that I'll just sort of ask, one thing is the things you do, as in orthobiologics or regenerative medicine. But that is secondary to your philosophy. And your philosophy is what I find to be extremely unique compared to, I'll say, traditional medicine and most everything that's out there. Because what I understand to be the difference is that while it appears that the goal of medicine or medical doctors is to get rid of the symptom, your goal at the Centeno-Schultz Clinic, very similar to many holistic practitioners, is to in fact find and correct the cause of the symptom. And that's a very different thing. It's sometimes analogous to is the goal to, if you have a fire and your fire alarm is going off, causing all types of noise, bothering you, interfering with your day, is the goal to get rid of the noise, as in the symptom, letting you know that something's wrong? Or is the goal to, in fact, put out the fire, the cause of the problem? Now, that would seem obvious when it relates to a fire, but what do you notice difference in that specific philosophy that most people are not understanding, either in, as your peers or as people coming into your practice going, okay, doc, what drugs do you have that the other docs don't have that is going to help me get rid of my pain? How do you explain that difference?
Yeah, absolutely. And I think that the fire is a great analogy. And I use a couple different ones, but I'm definitely going to start using the fire analogy when I talk to patients probably this afternoon. Um, And that's very true, and that's a really good way of putting it, because let's kind of briefly dive into just the shoulder. Oh, I have shoulder pain. The doc said I've got arthritis or I've got a labral tear or whatever. No, you have shoulder pain. Let's figure out why you're having shoulder pain, why your shoulder isn't functioning properly, which is resulting in you having accelerated arthritis, instability, pain, whatever it may be. And for a shoulder, for example, we're going to ask about your neck. We're likely going to ask about your elbow, your wrist, because just like the song we learned when we were 5, the ankle bone's connected to the knee bone, connected to the hip bone, and so on and so forth. It still rings true today. And kind of in an office setting, if you're working on a project with other people, if there's one person that's slacking off and not doing their job, all of the other people that's working on the project have to work overtime in order to finish the project. Well, they can only do that for so long until they reach their breaking point. And the human body is very similar. So if the signal that's coming from the nerves in the neck are not communicating the information properly to the rotator cuff muscles, the rotator cuff tendons and muscles aren't going to fire properly. So they're going to get angry and upset at some point. And the rotator cuff helps provide stability in the shoulder. So if you think of the shoulder kind of like a golf ball sitting on a sideways golf tee, we have a large golf ball, small golf tee. It requires a lot of stabilizing structures in order to keep that golf ball on that golf tee. The great thing about the shoulder is that we're able to do this. There's no other joint in the body where we have so much flexibility, so much range of motion. But the stability aspect comes as a detriment because it's inherently less stable than, let's say, the hip joint, for example, which is again a ball, but it's a much deeper socket than a little golf tee that the shoulder anatomy is. And so it's all about assessing all of the structures, whether that's just in the shoulder or in other areas, and then having the knowledge to be able to treat it when we find that there is something dysfunctional.
We just got a question from Chris, who I'm just going to ask in a second. Before I do, I'd love for you to break down. There's this misconception when people get a diagnosis, especially like arthritis, that it becomes very confusing. I've heard many people say, I've got fill in the blank arthritis, neck arthritis, spinal arthritis, degenerative joint disease, whatever it is. And it appears as if that becomes almost like a death sentence, a life sentence, you've got it. Help people understand the difference between sort of a terminal diagnosis and a functional diagnosis, as in something that's happening as a byproduct of the cause, which is different than you've got a disease going on that's uncurable and you just have to manage it.
Yeah, absolutely. And really, arthritis or Arthur, I've heard a million different terms for it. And that's really just wear and tear on a joint. And what I often tell patients is, congratulations, you've lived long enough to get arthritis. Because if you do live long enough, we will all get it at some point. Just like in a car, for example, a car that has 300,000 miles has probably had some parts replaced. Not that we want to do that in your body, but needs a lot more maintenance and upkeep than a car that's right off the showroom floor. Human body's no different. But what I often tell patients is that, well, if we think of every 90 and 100-year-old on the planet, and there's millions of them, they have arthritis in every single joint in their body because those parts are 90 and 100 years old. Yet we still have, I just heard a story about a 104-year-old who set a world record in the 100-meter dash. I'm sure for their age group, but still, we have, people, centenarians, I guess, over 100 years old, that are still functional and they don't have pain everywhere in their body, even though they have arthritis. Wear and tear of that smooth joint surface that's in every single joint from the tip of our pinky, all the way down up to our neck, all the way down into the tips of our toes, and everywhere in between.
It
And so
becomes
it's not a death sentence, but we have to figure out, okay, so you're 30 and you have advanced arthritis. Why did that happen? Did you have an ACL reconstruction when you were a teenager because you tore your ACL and you had a little bit of clean out in the knee where they trim part of the meniscus, which we know that if you have an ACL reconstruction in your teens, the likelihood of developing accelerated arthritis by the time you're 30 is much, much, much higher than somebody that hasn't had any knee surgeries.
it's essential that people understand what the problem is, because if you don't understand what the problem is, you certainly are going to have a far more difficult time understanding how to find the right solution for it. And
Absolutely.
so the term arthritis can be very confusing. It's not a systemic blood disorder like some arthritis can be. It's inflammation of the joint. So if you can figure out what's causing that inflammation, you actually then can decrease that inflammation, and the itis part of the arth, meaning joint, no longer has to be there. So let's take some questions. That's what this show is all about. We've got Chris, who's asking, he's got two questions here. I'll ask them both. One, I've read in the Centeno blog that anti-inflammatories make stem cells turn into fat. Do you have any opinion about Xarelto rivaroxaban? And then two, he's asking, what about treatment of bursitis on the shoulder? You address both of those?
Yeah, absolutely. So Xarelto rivaroxaban is an anticoagulant medication often used for atrial fibrillation. So basically, the heart pumping doesn't pump in the normal rhythm, and that helps keep the blood very thin, because when the heart doesn't pump properly and the blood is of normal thickness, then some of that blood clots really well. We don't want that blood to clot in the heart chambers and then that blood get pumped to the brain, for example, because that can cause a stroke. Or if you have a valve replacement in your heart, if you have a history of a stroke or pulmonary embolism, or a number of different things, is why you're on a medication like that. I don't know your specific condition, but I have to imagine it's probably one of those. But it keeps the blood thin. So that's not necessarily an anti-inflammatory medication. We do treat patients that are on those types of medications, and there's requirements and restrictions where you would need to be off of it for a short period of time, and we get into communication with the doctor that prescribes that medication, because you need Xarelto in order for something to limit the possibility of something really bad happening. You don't need our orthopedic procedures in order for you to survive. If you were to have a stroke or a blood clot that goes to your lungs or something like that, that's something that's very severe and can cause severe debilitation or even kill you. So we monitor all of our patients' medications, make sure that they're on the proper medications that they need to be on, and if they need to go off of medications for a short period of time prior to one of our procedures, then um, then we can do that. Okay, so to answer the second question, bursitis in the shoulder. So it's probably the subacromial subdeltoid bursa. That's the most common. It sits right under the bone that's right here on the top of your shoulder. And so bursitis, bursa, which is a sac, itis is inflammation. So inflammation of that. So similar to arthritis, you have bursitis, but what's causing the bursitis? Is it the rotator cuff isn't able to move properly because you have nerve impingement coming from the neck? Do you have a small rotator cuff tear, which is resulting in instability? And by instability, I mean things moving more than they should. So we have that golf ball, we have that golf tee that it sits kind of sideways on. And so whenever we move our shoulder, so say we're just trying to move it like bird wings, so up and down like this, we don't want it to be doing this as we're trying to do that. And that's obviously very over exaggerated, but these structures in the shoulder, the ligaments and the rotator cuff tendons, are designed to help keep that golf ball sitting on that golf tee while we're moving around like this, not letting it go every which way, which can cause the bursitis, which can accelerate the arthritis, etc.
Let's dig a little bit deeper. Those are the causes of bursitis, but since this is a shoulder arthritis show episode today, let's go deep on that. What are some of the common symptoms that somebody might have who gets a diagnosis of shoulder bursitis? Sometimes that's a diagnosis that's just sort of, I've sort of critically heard it said, a person walks into a medical doctor, they go, I've got this pain in my shoulder, it's red, it's swollen, it feels inflamed. And then the doctor goes, well, you've got bursitis, which is basically the same thing the patient just told the doctor in English that he replies back in either Greek or Latin.
Yeah.
It's kind of a not so funny joke, but oftentimes the way diagnosis occurs. Yes, that is what's happening, but it doesn't give people the information to know, is this a recent problem? Is this a long-term problem? So let's break down some of the details so people can walk away with an understanding. one, what are the common symptoms of shoulder bursitis? And then after that, let's get into what are some of the common treatments that people might experience other places. But then let's get into what you guys do differently at the Centeno-Schultz Clinic. So let's start. What are some of the common symptoms somebody might have if they're experiencing either shoulder arthritis and or shoulder bursitis? Because often they can be misdiagnosed as one or the other.
Yes, absolutely. Common symptoms, really pain with any type of movement, specifically for bursitis or arthritis, depending on what we're dealing with. Um, Oftentimes, patients have difficulty bringing their shoulder out to the side and they have pain. And all I have to do is ask, "Where's your pain?" And they point right here on kind of the top outside of the shoulder. Um, and that could be from the rotator cuff, the main rotator cuff tendon, the supraspinatus, not firing appropriately. And it's got some swelling in the tendon itself, or some small tears in the tendon. And people say, "Oh, I've got a rotator cuff tear." Well, that's like saying, "Oh, I've got a car." Well, there's a million different types of cars out there. There's a million different types of, well, not a million, but you get the point. Lots of different types of rotator cuff tears. From, let's take this little piece of paper that I have in front of me. We can have a tear like this, and okay, that's a tear. We can also have a tear like that. Well, that's a tear as well. Two entirely different things that we are going to assess and potentially treat completely different. So there's not catch-all term in regards to like a tear, for example, but bursitis. So when we're trying to abduct our shoulder or kind of do like bird wings out to the side like this, we have the humeral head, so the ball, and then that bursa, which is normally like if you think of a garbage bag that you pull right off the roll, those two sides of the garbage bag are kind of stuck to each other. And while bursitis is when we're starting to fill that garbage bag with stuff, so it gets a lot bigger. If it's the garbage bag that you pull right off the roll, it sits right on top of that humeral head. Well, right above it is uh, is that bone that sits right here on the top of your shoulder, as well as that main rotator cuff tendon. So we have a lot of things that are going into a small space. And whenever that bag is nice and flat, not inflamed, not upset, well, everything's moving around nice and good. But whenever that gets bigger because there's fluid in it, then things aren't moving properly because we're trying to put more stuff into an already pretty compacted space. And and so whenever you do try and move, that's when it gets irritated. And again, arthritis is normal wear and tear. And just because you have arthritis doesn't necessarily mean you have to be in pain. What's causing that arthritis, what's causing that irritated, inflamed joint, is it could be one of a bunch of different things, but two primary things are instability of the shoulder. So, like I said earlier, we get stability by the ligaments, which act like pieces of duct tape holding bones together. And then we also get it from those rotator cuff muscles that help keep that golf ball on that golf tee. Well, um, as far as the ligaments are concerned, maybe you've had a dislocation or a subluxation of your shoulder, or you're just naturally hypermobile, meaning your ligaments are a little bit stretchier than the average person. So instead of being like a piece of duct tape, now your ligaments are acting like a rubber band. They're still holding things together, but there's a little bit more give, and there's small instabilities that move that golf ball around on that golf tee, which accelerates that arthritic process. It also creates an angry, upset joint environment. So we have anti-inflammatory cytokines or proteins that float throughout our body all the time, and we have pro-inflammatory ones. Those are kind of the angry ones, and we want it to be a more neutral or anti-inflammatory environment, not an angry, upset joint environment that creates more fluid, puts more fluid in that area, whether it's in the joint itself, whether it's in the bursa, and makes everything upset because there's more stuff, for lack of a better term, in an area where there shouldn't be a lot of stuff. And our body is built very properly the way it was designed. And when we add things that shouldn't necessarily be there, that's when we get pain, inflammation, etc.
We got a question from Pia that I'm going to take in just a moment. But what is so important for people to understand about exactly what you're talking about? What are some of the common causes? Obviously there's trauma, right? If you're a football player and you get hit in the shoulder, if you get into a car accident and your shoulder is directly involved, there's that specific trauma. But then there's the sort of less obvious stuff, like when you ask, well, do you sleep on your back, your stomach, or your side every night. What are some of the common things that people do that they may not obviously think? If you had an injury and you fell on it, that would be obvious. What are some of the non-obvious things that people might do that may be causing this and or irritating it? And Pia will take your question in just a moment.
Yeah, absolutely. So trauma is kind of a different animal, car crash, broken shoulder, whatever it is. But then we have these small things that accumulate over time. So, repetitive work environments where you're doing the same thing, where you're hitting a hammer all day or reaching up to grab something with that right shoulder. You do it 100 times a day. You do that for a 30, 40, 50-year career. Well, and when you are younger, it may be, oh, my shoulder aches a little bit, but it doesn't really bother me that much to do anything about. But that can accumulate over time where we get these small injuries that's almost kind of like a snowball rolling down a hill. Well, when it's a tiny little snowball, it's not that big of a deal. You probably don't see it going down the mountain. But whenever that avalanche comes down, that's when we start to see it. And so usually we get patients that once they get to the avalanche point, but we're trying to change the dichotomy here, and that you go get your teeth cleaned regularly every 6 months, every year, whatever it is. You go get your oil changed every how many thousand miles, etc. And we want to think of your orthopedic needs and concerns like that, because we want to take care of small things while they're small, because that's a less invasive treatment, probably a less costly treatment, shorter recovery time, so you can get back doing the things you want to do. And then some patients, whenever they get to the point where there's that avalanche coming down, then I may not be able to help you. If I don't think I can, I'm honest with the patients that we get to that point, and I say, I think you need to go see a surgeon. And maybe that's maybe a small percentage of the time, but I'll also have a conversation with the patient and say, I don't think you're a very good candidate for our procedures because of one of a bunch of different reasons. But if you're completely against surgery, we can try and do this as a treatment option, but it may not reach your goals. And I have that upfront and honest conversation with patients.
That's very much why I know you guys have the proactive program, is for people who think proactively. What a lot of people don't understand is that many of these, you mentioned the avalanche. Now, I often describe it as sort of the last straw on the camel. And so the camel's been collecting lots of straws for lots of years, and it was that last one that all of a sudden created an issue. But the issue didn't start on the last straw.
Yes.
It started with all the straws that have been accumulating all the way, thus creating, as you say, the avalanche. But that's important for people to realize, because then their expectations come into play. They go, well, wait a minute, this just happened a couple weeks ago when I slept funny. And the reality is it's been going on for years sleeping funny. It was just finally at a breaking point, not literally breaking, but at that point where it finally tipped over and created those types of symptoms. Pia's got two great questions here. She's thinking and putting these ideas together, which is phenomenal. Question number one, how can you know if the muscles are not firing due to compression in the neck? What do you look for? She says, I have CCI and now hypermobile shoulders. And then she goes on to ask, how long do you have major pain after PRP treatments in the shoulders? So you mentioned sort of the recovery process. Let's talk through, how do you know it's a problem? And if you do use PRP, what's that recovery time look like?
Yeah, absolutely. So to answer the first question, that comes really in our physical exam, and then our clinical evaluation of what you tell us, what you feel, what you experience. So we're testing your strength, we're testing your sensation, we're testing your range of motion, we're testing your reflexes, which a lot of those originate from the nerve signals that are sent. So it's not just, do you have the muscle strength, which the nerve has to send that communication signal to the muscle in order to fire properly, but it's also, that's why we're testing sensation down even in the hand, because those nerves that come from the bottom half of the neck supply the entire upper extremities, so all of the arms and the muscles that are functional in those areas, and then also the skin, because nerves can provide both motor movement, muscle contraction, as well as sensory, which is touch. So we utilize those those physical exam techniques and characteristics in order to make that determination. And then there's some other special tests specifically to the shoulder. And then hypermobility is a concern. Craniocervical instability patients, or CCI, is the acronym for that, often can have hypermobility, and sometimes that's not in one area. That could be in all areas. So your ligaments throughout your entire body could be a little bit stretchier than the average person. And second question, um, pain is a very subjective thing, and there's no way ever that I could tell how much pain Jason is in or how much pain you are in compared to anyone else. And we all experience pain differently. After a PRP treatment to the shoulder, I would say on average a few days. As far as an increased pain, because number one, we're putting needles in areas, and number two, we're trying to create that inflammatory response, because inflammation is the first phase of the overall healing response. And above all else, anything we do here, we're trying to get your body to heal itself. So we need to go through that inflammatory phase in order to get to the other phases of healing. So to answer there's not an easy answer to the question, but in the shoulders, the rotator cuff in specific tends to be a little bit more painful and a little bit longer than, let's say, a knee, for example. And my thought process on that is because gravity works all the time, and gravity is pushing your shoulder down, your arm bone, your humeral head down all the time. If you're laying on your back, it's pushing it towards the bed. If you're laying on your stomach, it's pushing it that way. Well, the rotator cuff muscles have to be engaged at least to some degree at all times in order to help keep that golf ball on that golf tee. So I think that's why the rotator cuff and the shoulder specifically do have a little bit more pain after a treatment procedure, and a little bit longer, maybe an extra day or so, than other areas. Just a quick anecdote. A family member of mine was treated for their neck some time ago, and during the physical exam also found a little tiny tendinopathy in one of the rotator cuff tendons. And he never had any shoulder issues, never bothered him, but we were here, so we went ahead and treated it. That night, he wasn't complaining about the pain in his neck. It was that shoulder that he was like, "How this really hurts," after we treated it. And we did a number of injections into the neck and one injection into the shoulder. And that's what he felt afterwards. So just a little anecdote.
Right on. It's so great to be able to share these experiences. Let's wrap up today's show by helping people understand if they're experiencing some sort of symptom. Might be the neck, might be the shoulder, something in that upper extremity area. If they've got a diagnosis, perhaps, of a shoulder arthritis, bursitis, or any other itis conversation that's been going on in the shoulder or upper extremity areas. Let's talk through what's the process. They reach out to you. I know if they're not local, you guys are in the Broomfield, Colorado, Boulder, Denver area. If they're not local to you, I know you do telehealth consults in the beginning. If after doing a series of questions and answers, perhaps even some exercises, you feel that you could possibly help them, they can come on. And why don't you talk us through, if somebody's going through something, they call, what happens next, and what's sort of the pathway for them to get towards the healing they ultimately need?
Yeah, absolutely. So you can reach out directly to the Centeno-Schultz Clinic or the Regenexx network. We have about 70, I think, there's 60 or 70 different Regenexx facilities. That's kind of our umbrella company of network physicians. But here at the Centeno-Schultz Clinic, like you said, we're based out of the Denver, Colorado suburbs. And if you don't live local, we do telemedicine visits. We have an education center, which would be the first point of contact where they would reach out to you and get some general information, provide you with the proper forms in order to fill out. It's kind of doing almost a self-assessment at home, and then you insert the information, and we as the physicians receive all of that documentation. And then for a telemed visit, we're doing similar to what you and I, Jason, are doing right now on the computer through Zoom, Skype, or whatever technology it is. And so we're asking questions about you, getting to learn about you, who you've seen in the past, what they've said, what medications they've been recommending, what medications you've taken, what's worked, what hasn't worked, if you've had any surgeries, what surgeries have you had. All of that comes into play when we're trying to accumulate all this information to provide a best possible diagnosis and then potential treatment option. And so we take all that information and then we say, hey, okay, do we have enough info with what we have to make an educated guess on what our, what the diagnosis is? And like, okay, then great if we have that. If not, we may get some more imaging, different types of imaging, go through therapy first, things like that. So that's kind of the pathway that I work through in either an in-person or telemedicine visit. So if you're out of town, we say, hey, we think we can help. This is going to be our tentative treatment plan. And I say tentative because if we're doing it via Skype or Zoom, I've never touched you. I've never laid my hands on you. And the physical exam is probably the most important thing where I get the most information from. So tentative treatment plan, come out to Colorado. It's beautiful right now. The mountains, we have a great view of the mountains from our office, and I look outside every single day because of that. And then so you come in, we do a in-person examination consultation where we're learning more information, doing the physical exam. If you've got any new pictures, any new images, any new tests, we review all that together. And then do a finalized treatment plan. And the first thing is, can I help you? That's the big question to answer. Because if I can't help a patient, I'm going to be honest and upfront. And like I've said before, I'm going to tell them that. And if I can, I'll say, hey, this is what I think is the problem, and this is what I think can best be a treatment option for you. Um, and then once we finalize a treatment plan, then we go forth and then perform the treatment, and then we see how you do. Not every patient responds 100%. That's our goal, obviously, but we're also realists, and we don't live in fairy tale world. And so all we're trying to do is get your body to heal itself in the best ability possible. It's not magic fairy dust. It's not anything special magic wise that we're doing. We're putting the things that we need to put in the right places in order to try and heal what we're trying to heal and get you back doing the things that you love to do. And that's what I love the most, is hearing patients after I've treated them or after they've gone through something, physical therapy, chiropractic, whatever it is. And then they say, I had a patient not that long ago, and he's back to walking 18 holes every Saturday and Sunday, has a bunch of golf trips planned, and I'm a big golfer, so that's where my mind goes all the time, and you know about that, Jason. But yeah, has all these golf trips planned for the winter and spring, and that excites me because he's able to go on these trips and play golf with his family and friends, and because that's what he loves to do. And I don't care whether it's golf, Ironmans, hiking, 14ers, climbing Mount Everest, or just being able to get on the ground and play with your grandkids. From one spectrum to the other, whatever's important to you is important to me.
I love it. There's a couple things you said as we wrap up today's show that I just want to make sure people are understanding and appreciating, at least the way I do. And that's one, it does take time to come up with an accurate diagnosis. Too many people, they go to the doctor, they've got the average 7-minute doctor's visit. They get some, Greek or Latin name for something that they've got, and all of a sudden they go, oh, look what I got. And then they figure out, what drug do I got to take to manage it, often for the rest of their lives. In spite of the fact that as of today's news, there were 100,000 people that died of overdose last year and so on. So it's just an insane kind of world. You guys actually, as part of your procedures, take the time up front to make sure that you actually understand what the problem is. That, I think, is so critical and important, because so many procedures and prescriptions are actually erroneously prescribed or done because they didn't spend the time up front to make sure they get it right. The second thing I love so much about what you guys do there is that you really are honest and upfront with people. You're in a situation, you've been there long enough, you guys are legendary within the profession. Most consumers don't know that, but doctors know you are the go-to place. And the reason you're the go-to place is because you're upfront with people. You know that your reputation is so important that the goal is not to get as many people in your office as you can. It's to only accept those people that you actually have a high degree of confidence that are going to make some improvements. And that really is a big difference, because there's not a lot of people out there that go, well, They just said they could help me, but they really didn't. You focus long term, and you really want to make sure that those people you say, yes, I'm willing to accept your case. That means you've got a high degree of confidence that they're going to make some improvement. Like you said, people heal at different rates. People wait too long. I know a lot of people on your proactive program get results quicker because, as you mentioned earlier, when you address smaller issues, they require smaller, cheaper solutions that you can heal from faster. When people with the same diagnosis wait until that last straw and then continue to wait because they hope it will go away, the problems continue to get much worse, and bigger problems require bigger solutions, oftentimes with a bigger price tag and a longer recovery time. So essential that people understand how that all works. And it's really important that people appreciate the difference of working with you guys in your practice. Any final comments, Doc?
You kept talking so long, it slipped my mind of what I was going to say. No, and I guess as a final thought is that it's your body, it's your life as a patient.
Sure, I'm on live. I'll be right there.
What I try and do is provide the most amount of information that I can to you so you can make the best decision for yourself, for your family, for your life, whatever it is. And you are the driver of the bus. I am the little GPS navigator that kind of helps provide suggestions as far as where you can go and what I think you can benefit from most. And I think that's really kind of the 30,000-foot view of what we do here and my philosophy as a physician.
Everyone here is very excited to hear what you have to say. Sorry for the background noise. Hey, listen, thanks everyone for watching our show. Sorry for the background noise. We love dogs here, and that's just what happens. We'll be back next Wednesday with another episode of Ask the Doc. Make sure you bring your questions. Please, if you know anyone
Somebody wants to go outside to potty.
who's experiencing shoulder problems, please share this video with them. Until next week, thanks for watching. Stay well, be kind, enjoy your day, Doc.
Thank you.